Let me introduce Dr. Kathy Anderson. She's a general pediatrician and integrative medicine physician who has been practicing in Bismarck, North Dakota for the past 10 years at Mid-Dakota Clinic and St. Alexis Medical Center. She has served as the chair of pediatrics at both of these institutions, has recently launched her own pediatric telemedicine practices, Nurturing Wellness Pediatrics. Originally from New York, Dr. Anderson completed her undergraduate and medical studies at Brown University before obtaining residency training in pediatrics through the University of Hawaii. She is board certified in general pediatrics and integrative medicine. Throughout her career, Dr. Anderson has been committed to the responsibility of serving as an expert in child health and wellness through education and advocacy, in addition to the clinical care she provides. She has worked with the Department of Health to help train on using Bright Futures, the AAP recommended EPSDT tool in practice to prevent child abuse North Dakota to improve systems around social and emotional screening for children between 0 and 3, and in 2016 served on the Senate Task Force on Substance-Exposed Infants. Dr. Anderson began her term as president of the North Dakota chapter of the American Academy of Pediatrics in July of 2019. She is also the regional champion for diversity and inclusion for the American Academy of Pediatrics. She is excited at opportunities for education, advocacy, and partnerships that lie ahead, especially in this time of great uncertainty and need. Please welcome Dr. Anderson.
Let's get started. This morning, we are going to talk about a very important topic, understanding the changing needs of our community, partnering to support the health of the whole child through COVID-19 and beyond. I have no financial or other disclosures, but as a pediatrician, my bias or my superpower is that I can see the world through a child's eyes. It makes decision-making more clear if we're thinking about both the short and long-term effects of our decisions, the wellness of individuals and families, and the sustainability of healthy communities. Our objectives for today: we're going to take an investigative journey on a very important health issue. We'll review North Dakota and U.S. kids demographics. We'll review North Dakota trends for pediatric mental health. We'll really dive in and explore the why. And then at the end of the presentation, we'll look forward to some collaborative solutions and including prevention as part of the solution. So who? We're talking about children this morning, children and adolescents. History will judge us by the difference we make in the everyday lives of children. Nelson Mandela. Where? National trends, North Dakota specific data. So in North Dakota, 180,000 children live in this state, and those are children between 0 and 18. 51% male, 49% female. There's been a 20% increase in children between 2010 and 2019. And a 23% of the population is 0 to 18. When we look at distribution by age, we can see that we're, pretty closely matched to the US national numbers as far as number of children that are 0 to 4, 5 to 11, 12 to 14, and 15 to 17. When we look at demographics by race in North Dakota, we can see that our race distribution is higher for white at 75%, and then higher for American Indian than national numbers at 8%. We think too much and feel too little. More than machinery, we need humanity. More than cleverness, we need kindness and gentleness. Charlie Chaplin. So what are we going to talk about this morning? We're going to talk about mental health. And I'll start with a definition so that we can all be on the same page. The World Health Organization defines mental health as a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution back to his or her community. Here are some mental health statistics from the US overall. 13 to 20% of US children and adolescents experience a mental disorder in a given year. The Great Smoky Mountains study followed a cohort of rural US youth since 1992. 19% of youth manifested impaired mental functioning without meeting the criteria for diagnosis as a mental disorder. Prevalence of mental health disorders and problems in children and adolescents is increasing. Suicide rates are now the second leading cause of death in young people 10 to 24 years of age. And 6 million children were considered disabled between 2010 and 2011, an increase from more than 15% from a decade earlier. The highest rates of reported neurodevelopmental and mental health disabilities were seen in children living in poverty. However, the greatest increase in number of reported neurodevelopmental and mental health disabilities were seen more recently in children from socially advantaged households, which they define as 400% above the poverty level. An estimated 75% of children with mental health disorders go untreated. And primary care physicians are the sole physician managers of care for an estimated 4 in 10 US children with ADHD and 1/3 of children with mental health disorders overall. So when we're talking about right now, a lot of the data that we're going to go through is data compiled for North Dakota between 2007 and 2019. None of this data is during the pandemic. We know that pediatric mental health, all of our mental health really has suffered through the COVID-19 pandemic. And so we've seen, a rapid acceleration of worsening of pediatric mental health in the past 2 years. Let's look at the data. This data is being drawn from the Youth Behavioral Risk Survey. And this survey really, it's initially collected for kids 9th through 12th grade, but as you'll see in the following graphs, they also started in the later years to collect data on middle schoolers. It asks questions about behaviors contributing to unintentional injury, sexual behaviors that contribute to HIV, tobacco use, alcohol and other drug use, unhealthy dietary behaviors, physical inactivity, and then also about mental health. Don't you ever let a soul in the world tell you that you can't be exactly who you are. Lady Gaga. All right, so this is North Dakota data. This is showing us the percentage of students who felt sad or hopeless almost every day for 2 weeks in a row so that they stopped doing some usual activities ever during the 12 months prior to the survey. The darker line that is the higher above line is for high school students. And we can see that between 2007 and 2019, there's been a steady rise in that age group. Even between 2017 and 2019, actually, for the middle school age group, we can see a rise. The percentage of students who ever seriously thought about killing themselves. This question was asked of both groups during the course of the study, and we can see that there has been a steady increase, especially steady in that middle school group. Percentage of students who made a plan about how they would attempt suicide during the 12 months prior to the survey. And this is for high school and middle school students. And we can see that really, this data is overlapping, and we're looking at about 15% in 2019. The percentage of students who attempted suicide 1 or more times during the 12 months prior to the survey. And we can see for this that high school and middle school students we've seen a rise in, and really between 2017 and 2019, we saw quite a steep rise in those middle school students. These mountains that you are carrying, you are only supposed to climb. So really the question is why? Why are we seeing these trends? And remember, the trends that I've shown you are trends that precede COVID. Why are we seeing such a rise in mental health challenges in our children? Not just in North Dakota, but nationwide. We do follow national trends. I think the reason that we're seeing this is related to bias, and we're going to go into each of these reasons. So kind of the sentiment that conversations of health should not include mental health. Culture, it's not my problem. Discomfort with discussing mental health. And then lack of understanding and acceptance of well-documented causes for mental health. So we're going to talk about bias. I don't know if some of you guys were in that health equity talk yesterday afternoon, where you may have gone into some of this, but we'll go into definitions first. Bias is a natural inclination for or against an idea, object, group, or individual. It's often learned, and it's really dependent on variables like a person's socioeconomic status, race, ethnicity, educational background, and mental health status. So starting at a young age, people discriminate between those who are like them or they're in group and those who are not like them, they're out group. Think about, activities that we ask children to do, like, can you put all the red blocks over here? Can you put all the blue blocks over there? We're taught to differentiate. We're taught to discriminate. On the plus side, this can allow children to develop a sense of identity and safety, but when taken to the extreme, it can lead to harmful prejudice. People are naturally biased. They like certain things, they dislike other things, often without being fully conscious of their prejudice. Generally, people cannot be unbiased. Everyone has some degree of bias. This results from a lifetime of conditioning by schools, by religious institutions, by families, by media. But bias can be reduced. And really, it can be reduced if we start to have these conversations where we're reflecting critically on judgments and being aware of our own blind spots. We can avoid stereotyping and acting on harmful prejudice. So what does bias really affect? It affects the questions we ask. So, when we're doing research studies, medical research studies, our own bias on how we think things happen affects the questions that we ask. And then it affects the answers we get because we're looking for answers to the narrow questions that we might be asking. What else does bias affect? It affects the laws that we make. Historically, if we look at different laws in different areas, housing laws are ones where we can see that they really did affect who lived in different neighborhoods or who was able to live in different neighborhoods. Bias affects the way that we see and make sense of the world around us. And this is an important one when we think about children. Children are constantly trying to make sense of the world around them. They're observing the world around them, they're gathering data, and they're trying to put things together. So just thinking about how we frame that for them, what we expose them to, what we don't expose them to, and how that affects how they see the world. Bias affects the way that we, both as individuals and as a community and society, treat others. And finally, it affects the way that we as individuals and as a community and society teach our children to see the world around them and their place within it. So what are some everyday examples of bias in language? Boys will be boys. This is one I think that is still, very commonly used. It's obviously a gendered expression. The thing that's concerning outside of that about this is it's often used as it relates to and aggressive behaviors. And we know bullying and aggressive behaviors, both on the part of the bully and on the part of the child who is being bullied, are risk factors for mental health issues, for depression, anxiety, moving forward. Think of other words we use: blacklist, black sheep of the family. And the connotation with these words are that Black is bad or outcast or discluded in a group. Geriatric pregnancy. So, this is looking at age as a discriminating factor. And for those of you out there who may have been categorized as a geriatric pregnancy, I know I was for one of my pregnancies, and it hits really hard, but it's used in medicine for women over 35. So, I mean, we can think about how we could change that term as well. Bias affects how we describe others. It assumes a gender norm. So we might say that, we're in a hospital and we're being cared for by a male nurse rather than a nurse, or by a woman doctor rather than a doctor, because the norm for both of those would be the other. So just being aware of the way that we use language helps us to have better insight on where our own biases may lie. So just remember, your words have power, so use them wisely. Now we're going to jump into culture. Culture is the way of life of a group of people, the beliefs, behaviors, values, and symbols that they accept and that are passed on by communication and imitation from one generation to the next. They're learned and deliberately perpetuated through their institutions. So simply put, culture is the self-sustaining pattern of behavior that determines how things are done. It's that glue that connects individuals, sometimes across space and time, not just to each other, but to each individual's innermost values and motivation. So what are our culture's beliefs on mental health? If I talk about mental health, then that means I have a problem. So that means that if I don't talk about mental health, I don't have a problem. You can already see where some of these thoughts are concerning, especially when we think about those graphs that we saw where we're seeing a rise in mental health challenges in our youth, serious mental health challenges in our youth. The thought that many may have of that person should be taking better care of their mental health. That person's mental health issue is not my problem. And so just, considering, I don't actually let my kids watch the news. We don't watch the news in our house. I read the news. And the reason for that is because there's a lot of bad stuff going on. If I think just about the last 2 weeks of national news, I think there have been at least 3 shootings, a couple workplace shootings in California, another shooting in Florida that was at a nightclub. And so, just thinking about the last 2 statements here on this page, and realizing that other people's mental health challenges are all of our problems. They threaten the safety of our communities. They threaten the safety of our children. And, from a humanistic perspective, really, we should be concerned, not just for our own safety, but also for the health and well-being of those that we share our community with. So the problem with bias in culture is that if culture is the way of life of a group of people, and we live in increasingly diverse communities with regard to race, religion, place of origin, mental health challenges, and we all have biases, how do we create a culture that is inclusive of the differences that are present within and between groups? And how do we support the need of all members, or at least those that are most vulnerable? So, many of you might not be where I'm at. Why should we make this our goal? It's clear that what we've been doing is not working. It's not working for many adults, but in the data that I've shown you, it's really not working for our kids. We're seeing a breakdown in our ability to maintain a healthy outlook for children at younger and younger ages, and this is concerning. We need to create environments where individuals and groups are not included and not supported. It will lead to environments that are unsafe for all. So then it's our problem. You know, those shootings that are happening randomly, those become our problem. Doing the same thing over and over and expecting a different outcome is the definition of insanity. So I think what we need to do is kind of look broadly at this issue and kind of reframe our approach. Emancipate yourself from mental slavery. None but ourselves can free our minds. So now we're going to jump into the lack of understanding and acceptance of well-documented risk factors for mental illness. First, some quick mental health facts. Did you know more than 90% of people who die by suicide show symptoms of a mental health condition? In a survey, 80% of employees stated that workplace stress affected their personal relationships. Each day, an estimated 18 to 22 veterans die by suicide. People with ADHD are 18 times as likely to be disciplined for behavior or other work problems and likely to earn 20% to 40% less money than others. 1/3 of individuals with a chronic illness experience symptoms of depression. According to the World Health Organization, depression is projected to become the second leading contributor to the global burden of disease by 2020. And I think, I haven't seen recent numbers for that, but I think we may have not collected it related to the COVID pandemic. Up to 80% of those treated for depression show an improvement in their symptoms generally within 4 to 6 weeks of beginning treatment. Depression is more common than AIDS, cancer, and diabetes combined. People with depression are 4 times as likely to develop a heart attack than those without the illness. Among the 20.2 million adults in the US who experienced a substance use disorder, 50%, or half of them, had a co-occurring mental illness. And 9.6 million adults in the US experienced suicidal ideation. 50% of mental health disorders begin before age 14 and 75% before age 24. Suicide is the second leading cause of death among youth, 15 to 29, and some data also shows down to 10 years old. The leading cause of disability worldwide is mental health. So what are the protective factors against mental health? Against mental illness? Secure attachment as a child, healthy diet, exercise, and development, emotional self-regulation, good coping skills and problem-solving skills, healthy food and beverage choices, participation in a sports team, a club, community, or religious group, access to support services. This is a challenge, and then a set of moral beliefs. What are risk factors for mental illness? Use of alcohol or drugs, poor nutrition and lack of sleep, a family history of mental health problems. Being a stressful life situation, such as financial problems or breaking the law, being abused or neglected as a child, being in an abusive relationship or friendship, bullying either as the victim or perpetrator, growing up or currently living in poverty, discrimination, lack of access to support services, inherently flawed beyond repair. So what supports mental health? A healthy diet, regular exercise, restful sleep, avoidance of substances, self-care, mindfulness, grounding, recognizing and avoiding burnout, recognizing and avoiding perfectionism. Support systems containing good friends and family, a positive work and school environment, healthy dreams and aspirations, a good set of morals and belief in a higher being. It is no measure of health to be well adjusted to a profoundly sick society. Jiddu Krishnamurti. So I'm going to jump into the adverse childhood experiences study, and we'll see some overlaps and similarities with the data that I just presented on mental health. Basically, the study was done based off of an observation that a physician in California made that people with certain diagnoses as adults often had a history of challenges that occurred in childhood. This study has been conducted and duplicated numerous times and has, shown strong associations between adverse experiences in childhood and the effect on disease. So what we're seeing here in this pictorial is the diseases that we see as a result of adverse childhood experiences: lack of physical activity, smoking, alcoholism, drug use, and missed work. Physical and mental health issues as well: severe obesity, heart disease, diabetes, cancer, depression, stroke, suicide attempts, COPD, STDs, and broken bones. Now, what are the causes that were found to be associated with these diseases? Abuse, physical, emotional, or sexual; neglect, physical or emotional; or household dysfunction, which includes mental illness within the household, incarcerated relative, mother who's treated violently, substance abuse, divorce. And if I just jump back to the risk factors for mental illness, we can see that many of these risk factors have been confirmed through the adverse childhood experiences to also be the risk factors associated with disease. Now, this shows us what the degree of impact we could make if we prevented the adverse childhood experiences from occurring. So for example, the way that you would read this is if we look at suicide right around 6 o'clock on this chart, we would be able to reduce suicide by 67% if we focused on reduction of adverse childhood experiences. When we look at recent depression, we'd be able to reduce that by 40%. When we look at anxiety, by 55.7%. And then, we can look at alcohol and binge drinking, 32%, marijuana use, 54%. So I've always been a strong believer that knowledge is power. And so, after going through this information with you, I hope that you feel empowered, that not only that you understand a little bit more what children and adolescents in our community are experiencing right now, but also that you understand some of the things that we could work better to prevent and teach to decrease the stress on our youth. So if we all know that the protective factors, what the protective factors and risk factors are for mental illness, and that adverse childhood experiences can account for many of the risk factors, then we have the knowledge to be able to prevent suffering and disease by developing policies and programs that increase protective factors and decrease risk factors for all members of our community. The American Academy of Pediatrics, which is the professional organization for pediatricians and those caring for children and adolescents, has come out with multiple statements on this. And really what we have been trying to do is to improve access to mental health care by improving competencies in primary care providers, whether they're physicians, nurse practitioners, physician assistants. Because as you all, may already know, access to mental health care is really, really difficult. Waits are 4 to 6 months sometimes for a psychologist or a psychiatrist. And, if you have an active mental health challenge, that's not sufficient. 4 to 6 months is not sufficient. And as we know, both for the risk factors and protective factors that we discussed before, access to resources and to care was both, a protective factor and a risk factor if we didn't have it. Basically, what the focus has been on with the AAP Pediatric Mental Health Crisis Policy Statement is to focus on the impact of adverse childhood experiences and social determinants of health on mental health, to provide trauma-informed practice and team-based care, and then to recognize ways in which the competencies are pertinent to pediatric subspecialty practice as well. As we know, for adults and children with chronic illness, the risk of having mental illness is higher as well. And so these are the specific competencies that have been recommended for pediatricians and other providers caring for children to learn. But there's also been a call to the administration, because this is a national, really a national epidemic that we're experiencing. And we're seeing an increase with COVID, but the worsening started before COVID. So there was something unrelated to COVID that we could have been doing better, and that we still can do better. So really, how do we make things better, and how do we change the trajectory of pediatric mental health? I can tell you that equipping physicians, primary care providers, and nurse practitioners and PAs seeing children to be able to better identify and treat pediatric mental health issues is one step, but it doesn't address the root problem. It increases our workforce for accessing children that are currently in need. But there's such a huge gap, it doesn't completely resolve that issue. And so we need to do more. We need to increase understanding. And that hopefully I've started to chip away a little bit through this presentation. We need to encourage collaboration and innovation. So, we don't just consider our mental health when we go to the doctor. Why is it that our response to mental health is primarily from the doctor? It's really a Band-Aid. It's not helping us decrease suffering in these children, because we haven't changed anything that has led up to the issues that our youth are experiencing right now. So we need to work collaboratively. We need to work together in all the places that our children go, in their medical homes, in their actual homes, in their schools, in their daycares. We really need to educate and teach the wraparound places where children are, how to support their mental health, and how to teach children as they get older to support their own mental health. We need to develop comprehensive models for assessing value. I know that lots of the discussions around mental health are, related to, well, it costs money to put this program together. Why is there a need? And if those graphs that I provided you with earlier don't show you a need, then I'm not sure what will. But the cost of care, the cost of hospitalization, the cost of pharmaceuticals if they're needed, the cost of therapy, just the financial cost is high, much less, assessing the cost of suffering in children and adolescents. And so we need to really invest where it counts most. And then we need to support policies with these principles in mind. Really, we need to use the scientific evidence we have in trauma, toxic stress, and adverse childhood experiences to recenter the discussion of holistic child and adult health. So when we're talking about holistic health, we're talking about understanding holistically health, disease, healing, and wellness. We are talking about the protective factors that I just discussed as it relates to mental health: movement, exercise, healthy food, sleep. We think of these as basic, almost to the point that we don't discuss how important they are for each of our lives. And, if we look at how much time we spend doing these different things, we may recognize that if we're really thinking about supporting health, where we're dedicating our time is significantly unbalanced. And maybe that's a reason that we're seeing a rise. So we think about movement and exercise. We think about nutrition, healthy food. We think about the importance of sleep, the importance of a healthy and safe physical environment. We think about relationships and how do we support healthy relationships. And that's where I think, some of the partnership needs to be with programs that help families and teach parents and families how to engage with their youth and what the stresses of youth are. Because we may have not had the same conversations with our parents, and our parents may not have had those same conversations with their parents. We need to talk about growth and spirituality and how we cultivate that within our children and how we cultivate that within ourselves as we grow. And then we need to think about the mind and the body and how that's connected. When we look at disease, there are many and rising numbers of diseases where we see that there is both a psychological component to the disease and a physical component to the disease. More common ones that we think about are like fibromyalgia, but in children, functional abdominal pain, tummy aches are often related to something else that's going on, anxiety or that queasy feeling. So, just thinking about the importance of connecting things, connecting the whole child, and then connecting that whole child to their environment. And so we can't compartmentalize health. We've tried and it's not working. We are all observing, learning, feeling, and living all of the time. So why did we think that compartmentalizing a child's life would benefit them? The different places a child lives, in their school, in their community, in their medical home, in their extended family home, these are all the places that health behaviors need to exist and be practiced. We as adults cannot continue to compartmentalize our children's lives or our own without acceptance of the toll that it takes. So we need to commit to the necessity of collaboration and coordination with parents, with schools, with physicians, with policymakers, with the legal system, and within our communities. We need to get comfortable having uncomfortable conversations. Nobody likes to talk about mental health. We don't like to ask our children about how they're feeling. We don't want to know the answer, even if we're suspecting it. I can tell you, that many times when we're screening for depression or just as a standard recommended screen, or if we have a child that's coming in with sleep issues or abdominal pain, we find that there are underlying mental health challenges that are occurring. We find that there is bullying occurring at the school, and that's the reason that they don't want to go there. We find that the bullying is affecting how they feel about themselves and that they are sad and angry about it. And oftentimes parents are unaware and haven't had these discussions before we help to facilitate them. And I think some of that is that many of our generation and generations before us did not talk about mental health. It was taboo to discuss. We didn't develop a language for discussing mental health, and we don't have a comfort with it because it wasn't practiced. And so we really need to change that with our children. And it, like any change, it is going to take work, but it's also going to take some directed skill development. We need to have uncomfortable conversations about our mental health with our spouses, in schools, in communities, and as legislators and policymakers. When we look at the value of prevention, and this is from the Harvard Center on the Developing Child, these are 3 different programs that are early childhood programs, and they look at the long-term benefits of investing $1 into these early childhood programs and what they've shown when they follow children through age 21 or through age 40, for example. And these savings are calculated based off of, the work, their contribution back to their community, their avoidance of entering the system, and, need for legal or incarceration costs. So how do we address the mental health epidemic? We need to invest in programs that support children and families, understanding what the return on investment is. We need to build programs to support those currently in need. And one of the programs in our state is the Pediatric Mental Health Care Access Grant, which is helping to equip primary care providers with information and access to mental health providers so that we can better care for our patients. So we are developing these programs. We need to consider what policies, practices, or lack thereof created this epidemic. And we need to address the problem upstream, because we can't just stop the bleeding of a leg and expect that it is going to stop if we don't figure out what caused it before that, the car accident that caused it. So the Harvard Center on the Developing Child has some great resources about the importance of the focus on development and how it affects not just children and families, but our society overall. There are also some great videos there, and I am going to see if we can.
Of a successful society rests on the health and competence of its population.
Are you all able to hear this video?
It's just common sense to conclude.
Are you all able to hear this video, or do I need to?
Nope, it's good. We can hear it.
Okay, perfect. Okay.
The foundations of a successful society rest on the health and competence of its population. It's just common sense to conclude that what happens early in life sets a foundation for everything that follows. What's exciting about the revolution that we're living through right now in biological science is that we're beginning to understand at the molecular level why that's true.
The biology of health and development is really the link that is formed between the experiences that we have, both positive and negative, within our families, within our relationships, communities, neighborhoods, and so on, and the kinds of health experiences and developmental experiences that we sustain over a lifetime.
Advances in neuroscience, molecular biology, and genomics have a very simple message that has tremendous impact for thinking about policies for young children. That message is that early experience literally is built into our bodies, for better or for worse.
If as young children we encounter recurrent or chronic stressors that are within this category of toxic stress, we begin to sustain a kind of cumulative wear and tear on the biological systems of the body, on the cardiovascular system, on the neuroendocrine system, on the systems of the brain. And over months and years of time, this cumulative exposure begins to break down or change the functioning of those systems in ways that can lead to disease and disorder.
People who have had these adverse events in their lives and not had consistent parenting, have been abused or neglected, will lack this ability to show good emotional control, will have difficulty learning, and will show problems in health, increased risk for obesity, diabetes, cardiovascular disease, and even a shorter lifespan.
So the question then becomes, how do we influence the health of those young children? And there we know that there's a strong interaction between the underlying biology, the genetic makeup, and the environment.
So extensive research from multiple perspectives leads us to identify three basic foundations of lifelong health that are laid down in early childhood. The first is the environment of relationships in which a child is living.
We know that warm, responsive relationships are part of brain development. They're part of the developing feelings of security and close attachment. And those translate into better health because they allow infants to develop all those other systems, including neuroendocrine and inflammatory responses and brain development that lead to better health.
The second foundation of healthy development is a safe physical environment that promotes good health and protects children from harm.
Creating safe environments for children, both built environments, play environments, protecting them from hazards in those environments, whether it's lead or some other toxin, whether it's tobacco smoke in the home. All of those are things that relate to, again, the development of the child's systems. And then finally, a third foundation is good nutrition. And there we're thinking not only of micronutrition, all the micronutrients, vitamins, minerals, and so forth, but also macronutrition, a good composition of the diet in terms of fat, in terms of protein, and so forth, but also the availability of food in the community.
One of the things we have learned, and the scientific evidence on this is quite clear, that where we live, learn, work, and play have a bigger impact on our health than going to the doctor. Now, please don't misunderstand me. Going for medical care is important, but what are the factors that determine whether we are sick or healthy in the first place have to do with the opportunities for health in the places where we spend most of our time. Our homes, our communities, our schools, our workplaces. And the policies in those places can make it easy or harder for us to live healthy lives.
And in policy terms, that really points us in two directions. One is the extent to which we fortify the first line of support for children, which is in their families. But the second message is very clear that it's not just the family that provides a sense of protection for children. This is a much broader issue that's really a community responsibility.
There are many ways in which communities can influence the health and well-being of our children. Opportunities for social interaction within communities that brings parents and other community residents together. That is beneficial for the kids. There's actually some research that suggests that's beneficial for the adults as well, their engagement with young people. We can think of other ways and other institutions in the communities that can play a role. Churches and religious institutions can play a role. Certainly libraries can play a role. What we're talking about is the entire community being a village that provides the support and the nurturing for the development of our children.
There are very few social policies that do not have an impact on the health and the well-being of young children. Some are obvious: childcare, early education, provision of healthcare. Some are less obvious, but clear to most people, like how we deal with maternal employment and how we provide services through a child welfare system. Some of them may not be obvious at all, like the extent to which zoning regulations make it easier or more difficult for a community to provide grocery stores with fresh vegetables as opposed to liquor stores and fast food outlets. The question is much more, how is any of these or all of these policy streams addressing the fundamental challenge, which is how we can reduce the sources of adversity in children's lives so that we can reduce the toxic stress they experience.
There have been recent analyses that document that the costs to society of disparities are enormous. If all Americans had a health of the college educated, the US economy would save $1 trillion each year. So those are enormous disparities.
People like to say that children's health is our nation's wealth. But until we really start to act on these ideas of how do we promote health in the earliest part of life, we will not get to being a healthier population and a more prosperous society.
Five minutes left, Dr. Anderson, and we do have a number of questions. So,
Okay, well, I can just,
Nuestro cerebro es para pensar en.
please stand by. We might have locked off Dr. Anderson. There she is. Welcome back.
yeah. Closed, Google Chrome, I closed all of you guys. The last thing I'll just say to close that up, I hope that every time I watch that video, it is painful to watch, and it inspires me into action. My hope today, this morning, and for all of you moving forward, is that this talk this morning made all of you feel at least a little bit uncomfortable. My hope is that feeling of discomfort inside will force you into action through collaboration with partners within our community and across the state. And I also hope that this talk has helped to kind of show you that really this is all of our responsibility to work together to improve the lives of our children and adolescents. Thank you.
There are several questions in the chat box. I'll read them. One of them asked about where there's other resources, and I think Shonda provided a link in the chat area, so that question is answered. We'll try to get through all these if we can. First one from Mark Strand. What's the role of local public health in collaboration with the medical system to improve mental health in the youth of our population?
You know, that's a great question, and you know, the question itself makes me feel like I've achieved one of my goals, which is to move all of us here into action. So I think that you know, all relationships start with a conversation, and someone needs to be that conversation starter. The data for youth mental health across our state is strong. It's worsening. What we've been doing is not sufficient. I know that there are providers, and I was a provider myself until I realized that, you know, there has been such an increase and there's such a need, who was not as comfortable treating mental health. We don't spend a lot of time training on this. And so, you know, raising awareness, thank you for adding the pediatric mental health teleechoes. Raising awareness, raising education and educational opportunities, and then starting conversations. All of our communities here across North Dakota are going to look a little different, but I think that public health, the medical team, the medical home, schools are huge. Obviously are going to need to be part of this conversation. So I think the first step is just reaching out, and the conversation starter can be, you know, I went to the Rural Health Conference, I saw this presentation, I was really troubled by this information, and I want to figure out how we can help.
Next question, describe the subtle demeanor of a child or teen who has a mental health problem. How can we as adults, parents, etc., recognize a problem early?
So that's a tough question. It looks different in each child. So just like our baseline temperaments can be different, our anxious or depressed temperaments can be different. So a withdrawal from activities, you know, lack of engagement with typical friends. For teenagers, it's hard because they do withdraw a little bit. They don't want to talk with parents quite as much. And so making sure that there's a support system where they can access that, I really think it's important. And, obviously this is my bias as a, advocate for children and as a pediatrician. I really think it's important to have a medical home for your children. And the American Academy of Pediatrics recommends yearly well checks. Unfortunately, here in North Dakota and in other states, many insurance companies stop covering for well checks after children get their kindergarten immunizations. The problem with that is, and the reason they stop covering is because children don't get immunizations at their yearly well checks again until middle school. The problem is what we've seen is a development of worsening mental health issues in children younger and younger in that age group. And so to what extent does having this relationship with a trusted extended family member, your pediatrician, help to increase our awareness and to identify issues early so we can address them? Sleep issues can be a big thing. Obviously, behavioral issues in school or at home are an indicator that something else is going on. Bullying is a huge risk factor, and it's something that that angers me, but that I see and hear happening in so many children on a daily basis, that we're not regulating well. We're not teaching around well. We are not preventing. So I think your question is tough, but start those conversations early. Start to talk to your child when they're toddlers about their feelings. I can see that you feel angry right now. Why are you angry? Tell mom. And so they can identify what that big bad feeling is. There is a name to it. Mommy feels angry sometimes too. And then we can start to have these discussions. So I really think that that it requires partnership, and it requires a multidisciplinary approach, and it requires having partners that are committed to moving forward with improving the situation, the stressors on our youth.
There's time for one more question. There's a number of questions that are related to the presentation itself. I think, first of all, the session is recorded, so people will have a chance to go back and look at anything they want. And also, if you, the presentation should be available, just contact Kylie or Amy at the center. And Dr. Anderson, if you haven't, and you probably already have, but if you haven't, if you wouldn't mind sharing your presentation with Kylie or Amy, then they will share it with the participants that may request. The last is a real quick question, and I think we'll have to wrap up. Review again how long it takes for a child or a teen to get an appointment to see a mental health professional.
Right, it's going to be different in different communities. Here in Bismarck, it's probably about 4 months to get in with a psychiatrist. Probably similar to get in with a psychologist. For mental health counselors, there are places that are trying to increase access, but last week I had a family who called and it was a 2-month wait for a counselor. So we can't address this problem just by building capacity. We need to get to the root cause of why children are suffering, stressed, and why their mental health is worsening. And we need to build skills. In the UK, they have a mindfulness in schools program where they teach children self-regulatory skills. We really need to reevaluate what we're teaching our kids, because they're not living in the same world that we were 30 years ago. And if you are not safe and you are having issues with making sense of things and having challenges with mental health, you're not learning. So we need to really think about developmentally how we prioritize mental health as it relates to learning.
Dr. Anderson, thank you. With all the questions, obviously you stimulated a lot of thoughts, and I think your objective of making us all a little uncomfortable was achieved, certainly. Thank you for your time and your presentation. So thanks, Dr. Anderson, again.
Thank you.